So, good evening, everyone. I'd like to welcome you all and thank you for joining our webinar tonight on advances in gynecological endoscopy. My name is Amr Nabil Badawi. I'm obstetrics and gynecology consultant, researcher at National Research Center, and a board member of the Egyptian Representative Committee. So actually, this is the webinar number 20 that's organized by the Egyptian Representative Committee, which is the International Representative Committee of the RCOG in Egypt. So I would like to thank the fellows and members of the committee for their efforts, and special thanks to Professor Yasser Abu Talib, chair of the committee, for his incredible dedication and support. So his outstanding work and encouragement has been very crucial in bringing this event to life. Thank you very much. A gentle reminder that all of our Egyptian Representative Committee activities are available on our newly launched website and official YouTube channel. I would like also to express my deep appreciation to our esteemed speakers for tonight, Professor Amr Al-Husseini, Professor Gasser Al-Bishri, and Professor Muhammad Mabrouk. They are elite experts in gynecological endoscopy, and we're so lucky to have them tonight. So thank you very much. I would like also to thank Star Company for sponsoring this event. So today's webinar on advances in gynecological endoscopy dives into one of the most important areas in gynecology, as laparoscopy has become very common procedure. Our webinar comprises of 3 sessions. Each session will take approximately 20 minutes with 5 minutes for discussion following each session. So please feel free to submit your questions using the Q&A button, and we will do our best to answer all of your questions. So I will introduce my dear Professor Yasser Abu Talib for the welcome note and opening. Professor Yasser is the chair of the Egyptian Representative Committee of the RCOG, professor of obstetrics and gynecology at Ain Shams University, and professor of obstetrics and gynecology at Army College of Medicine. So please, Dr. Yasser, start your presentation. Thank you very much. Dr. Yasser?
Yes. Okay. So, can you hear me?
Yes, we can hear you well, Dr. Yasser.
Okay, that's fine. So, good evening, everyone. It's my great pleasure to be here presenting my colleagues for this wonderful webinar. I think endoscopy is one of the estimated things all over the world, and it's very important to go through this issue. It's our pleasure actually to be with my colleague, Professor Dr. Amr Husseini, the head of the Obstetric and Gynecology Department at Ain Shams University. He's an esteemed person that I like very much. He has lots of achievement, and he's settled nowadays a very important unit in endoscopy. He's well known for everyone with his achievement. To meet him today and to introduce him to everyone, and I think everyone knows Professor Dr. Amr Husseini well for his achievement. And I know well that everyone that know that he's a very nice guy, friendly for everyone. Hi, Amr, and it's a pleasure actually to be with us. Thank you very much.
Thank you very much.
As well, it's a great pleasure to introduce Professor Dr. Gasser Bishri, who used to be a friend of mine and a brother, as well as we spent long time back in England, spending long time working together and go out together. And his family is in a great bond with me. And I saw myself his achievement. He's a unique person in endoscopy, and we used to have regular course of TLH and endoscopic advances in endoscopy in Shams University over the last maybe 5 or 6 years. And it's a great pleasure actually to meet Professor Dr. Gasser al-Bishri after a long time of trying to contact him because he's a very busy guy working 24/7. So thank you very much to have this achievement, to invite both of you and to have a wonderful time with both of you. Thank you very much.
Thank you, yes, thank you very much for your
You're welcome. As well, Professor Dr. Mohammed from England. I think he's a little bit busy and he's going to join the team within maybe half an hour or something like that because he is still working on his list. So welcome you all, and thank you, Amr, for introducing me. It gives me a great pleasure actually to announce that we used to have regular webinar every 2 to 3 months to have a sort of communication and connection with everyone all over the world. It's considered as a scientific and social program as well, through which we used to know each other and to exchange knowledge as well. What's new that we are trying by all means to have a bond between Egyptian persons, British persons, and colleagues in the MENA region. What does it mean, MENA region? It means colleagues in 5 countries in the Middle East region. It's Jordan, Saudi Arabia, Qatar, Kuwait, and as well Dubai. So we used actually to join one of them, to join our meeting and to select one of the hot subjects and discuss it. We used to conduct this program over the last year, and we will have another in the future, another one in the future starting January, where we are going to discuss a very hot issue regarding to placenta accreta and antepartum hemorrhage. It's my great pleasure as well to announce our coming international meeting, which will be held in Egypt during the period between 11th and 12th December in Fifth Settlement in Egypt, where we are going to meet all of you. And you must know that we are doing our best to have a sort of connection and inviting many international people all over the world to attend this meeting. First of all, we invited the leaders of the Royal College of Obstetrics and Gynae, Rani Tucker, Hassan Shahata, Asma, and Sharif Abfatah. They are going to attend this meeting. And as well, from the MENA region, the chairpersons from the 5 countries will attend. As well, we were very keen to invite unique persons that all of you know them. Professor Dr. Mohammed Abul Ghar, Professor Dr. Gamal Abu Surur, Professor Dr. Hassan Salam are the leaders of this meeting. And as well, we have lots and lots and lots of invitees are going to attend this meeting. On the side of this meeting, we are going to arrange a sort of courses to improve your capability in working under the supervision of the Royal College of Obstetrics and Gynecology from England and from Egypt and from the MENA region as well. We will have Eurogyne course, which will be over 3 days. total laparoscopic hysterectomy course, which will be 2 days, and infertility course, which will be between 2 and 3 days, and as well fetal medicine course, which will be held in Ain Shams University, where we are going to conduct 2 days for fetal medicine and 1 day for invasive procedures as well. All the courses are hands-on. We are desperate actually to meet you there, and we hope to see you there just to have a good experience with different methodological methods that you are going to gain more information regarding to it. So it's our pleasure again to invite you all to this meeting. And again, thank you very much for all of you attending our webinar, and thanks very much for our great friends and consultant, and looking forward to see all of you. Amr, you can have the mic and start the webinar if you don't mind, please. Thank you very much.
Thank you very much, my dear Professor Yasser, for your presentation. And now I'm going to introduce our first speaker for tonight, Professor Amr El-Husseini. Professor Amr, he's a professor and head of the Obstetrics and Gynecology Department at Ain Shams University. Professor Amr is renowned for his expertise in robotic, laparoscopic, hysteroscopic, and colposcopic surgeries. He's also has a true passion for teaching and mentoring, made a huge impact on so many doctors by sharing his knowledge and always offering support. So thank you, Dr. Amr. Professor Amr will be presenting tonight on laparoscopic management of pelvic organ prolapse. So would you please start your presentation, Professor?
Thank you very much. It's a great pleasure to be invited to this very esteemed meeting. I'm really honored and thrilled to have that privilege. It's been a very long time ago when I was in the UK. It really revived a lot of emotions and sensations. First of all, I'd like to thank my lifelong friends and colleagues for very long time, Professor Yasser Abu Talib and Professor Gasser al-Bishri. These are like a family. We are family for a long time. I worked with Dr. Yasser and Dr. Gasser. Dr. Gasser, we worked together for a couple of years in Egypt, and then for a very long time in the UK and Egypt as well. Professor Dr. Yasser Abu Talib is a very close friend, and I'm one of his admirers for his amazing and relentless efforts to spread the knowledge and the training. I'm very glad to be with very close friends of mine. Thank you very much, Professor Yasser.
Thank you. Thank you.
Head of the Egyptian Representative Committee. One of the things that made me really thrilled that he became the president of the Egyptian Representative Committee, once upon a time held by Professor Maher Mahran. Dr. Yasser is a fighter, and I mean it by the real essence of the word. He's a champion in the martial arts, and I always keep this in my mind with any discussion with him. So I always keen not to upset him. Thank you very much, Dr. Amr Nabil, for inviting me. I wish all the best for the Egyptian Representative Committee under your presidency, and maybe in the future under Gasser al-Bishri presidency. These are truly remarkable achievers and truly remarkable doctors and scientists. I would like to introduce myself. My name is Amr El-Husseini. I would like to call myself someone who devoted himself for minimal access surgery training, at least for the past 25 years. I came back from the UK in the year 2000, and since that time I've done all I can to train myself and spread the training to others. Today I will present a presentation and video about the laparoscopic management of pelvic organ prolapse. Because of we are short and we are running short of time and we are running late, I'll try to show the video as quick as possible. But first of all, we have to know that we are presenting from Egypt. We are the history. Never forget this, even if our present is not as bright as our past. And in the present time, we have this hero. He is a proof of what persistence, perseverance can do. He achieved what we all dream of, becoming a world-renowned player. Even when I was in Thailand last year, when I said that I'm from Egypt, they said, Mohammed Salah country. So we are all very proud of him. Pelvic organ prolapse affect millions of women. Approximately 200,000 inpatient surgical procedures performed every year in the United States. And the apical prolapse is the descent of the uterus, cervix, or the vault. And the degree of pelvic dysfunction can be evaluated by the POP-Q system developed by the International Society, International Continence Society. And these are the stages. And it's very important to know the abbreviation so you can read and document your findings in the proper way. The risk factor vaginal delivery, especially complicated vaginal delivery, menopause, old age, overweight, increased intraperitoneal pressure, major surgery in the pelvis, connective tissue disorders like Marfan syndrome, and genetic predisposition. The symptoms are usually a bulge from the vagina, obstructive defecation or micturition, fetal or urinary incontinence, pelvic dragging, and pelvic pain are the usual presentation for these women. The treatment options, especially in minor cases, pelvic floor exercise, vaginal pessary, apical suspension, anterior and posterior wall prolapse repair, and obliterative procedure like Le Fort colpocolysis. But it's very important to say that only 1 out of 9 women will ever need a surgery. Not every patient is suitable for prolapse surgery. Why we prefer robotic or laparoscopic surgery over traditional surgery? Because it's much easier to access the pelvic support structures. The view is amazing. Everybody can learn. The learning curve is quicker when you use laparoscopy or the robot because everybody is seeing. I remember when I was doing colpopexy in a traditional surgery, nobody can see but myself. Even my assistant can hardly see. Nobody else in the room can see what you're doing. It's more effective because you see the tissue very well. It's less invasive. There's less complication rate and less recurrence. Usually we use a mesh, and the best choice for mesh is to use monofilamentous synthetic mesh like the polypropylene mesh. And these are the types of suspension we can use: hysteropexy, cervicopexy, colpopexy, and all are anchored to the sacral promontory. The hysteropexy has been growing in popularity. The uterus is attached to the sacral promontory with the mesh, which runs retroperitoneal, and it's very important to bury the mesh retroperitoneal below where the original attachment of the uterosacral ligament. And hysteropexy is indicated particularly in younger patients who wants to spare the uterus, and it does not have a negative effect on their sexual life. Let's go to the video. This lady is in her 40s. She is an engineer in BP, British Petroleum. So she's a very active woman. She works in the Middle East. She's traveling every day, and she's sexually active, so she doesn't want a change in her sexual life, and she's very keen to keep her uterus. The first thing I used to do in these procedures is to use a T-lift to take the bowel away from the pelvis, because this will make the procedure much easier. And then I start from the promontorum, and I always advise my colleagues, and I advise myself, to watch the right ureter. It's pretty close here. And you can see it. I'm using here a 4K camera from Karl Storz. And the best thing to do is to follow the uterosacral ligament. When I'm preparing the posterior peritoneum, I'm always bearing in mind that I want to cover the mesh completely once it's in place. So the preparation is very important. It's not just an incision. I'm just preparing the retroperitoneal area, the posterior peritoneum, to accommodate the mesh once I finish. And then I almost reach the uterosacral arch. My personal practice, and I think it's one of the innovations that I found very good in completely covering the mesh, is to extend the incision from the right uterosacral to the left uterosacral, because the bifurcation has to go through this. Once I finished preparation in the posterior peritoneum, I go to the anterior peritoneum, and I incise the bladder in the same way as if I'm going to do a laparoscopic hysterectomy. We dissect the bladder downward because we want to expose the cervix completely. Here, I'm using an ultrasound dissector. My opinion, this is one of the best tools that has been invented in the last 30 years. And you gently cut and push the pillars down, and you can do that all day. So you can bring the bladder down completely. And then I make a hole in the broad ligament away from the uterine vessels and away from the ureter. That's the right hole. And then a similar one on the left side. So I have finished my preparation. Now I'm introducing a Y-shaped polypropylene mesh. And this technique, sometimes called the cravat or the tie technique. You put a tie around the neck of the womb, around the cervix. So once you've done that, you take a stitch with non-absorbable suture, like Ethibond, for instance, like ethylone, and take the stitch to both arms of the Prolene mesh. In the same stitch, you take both arms and then place a couple of sutures at the front of the cervix. This is followed by suturing the peritoneum, and I added a Surgicel here for hemostasis, and I'm using a monofilamentous suture to do this. Having done that, I fix the mesh to the back of the cervix. So it's fixed in the front and in the back, and this will guarantee that it's well sutured and fixed in place. Then I lay it to the pelvis, and I use a helical tucker to fix the mesh to the promontora or the sacral promontory. You can use 2, 3, 4 maybe, but usually 2 are enough. And then I will cover the mesh completely in the place where I prepared the peritoneum to adapt the mesh, and using a monofilamentous suture also to cover it completely. So you can see we have created a new uterosacral ligaments, and then I add adhesion barrier between the bowel and the sutures, just to keep everything nice and clean. So the uterus is in place. Procedure time, usually less than 1 hour. You can do the same if you are removing the uterus. And if you are removing the uterus, you can still use a polypropylene mesh. One thing, if you are going to fix the vaginal vault, is to make sure that you dissect both the bladder and the rectum well down. So you will have here, I've done the hysterectomy. I don't usually use vaginal manipulator. And then I'm removing the uterus. And after that, I will make sure that I entered in the correct plane in the recto-vaginal septum and dissect the rectum down. So I have a free posterior vaginal wall, at least 2 to 3 centimeters before I take my sutures to close the vault. You can use barbed suture, you can use monofilamentous suture, you can use vicryl, if you're happy with that. You can use it in a continuous or interrupted pattern, whatever you like. But you have to make sure that you have dissected the space well done. After that, the same thing as we've done in the uteropexy, we open the posterior peritoneum at the level of the sacral promontory and dissect downward, guided by the uterosacral ligament. The same thing exactly. And then elevate the vault with a vault manipulator. You can expose the sacral promontory with a swab on a stick, and then apply the mesh. And in this case, we will suture one limb at the anterior wall of the vagina, and we have dissected the bladder at least 2 centimeters down, again with non-absorbable suture, and do the same with the posterior wall as we dissected the rectum well down. So now we fixed the 2 arms using non-absorbable suture to the front and back of the vaginal tube. The next step is to extend the mesh to the promontory and again use a tucker. By the way, there is an articulating tucker now, because this straight one is a little bit difficult to handle. So now there is an articulating tucker, which makes it very easy to exactly put the screws where you want them. And again, it's very essential to cover completely the mesh and make sure no parts of it are exposed, so you will not have any problem with mesh erosion to the bowel or the bladder or the vagina. So now, as you can see, the pelvis is well. There's very good hemostasis. You can test the bladder if you like. And the procedure, again, takes about an hour, and then finally adding an adhesion barrier. That's all. I would be very happy to take any questions from your kind selves. And thank you very much for having me. Thank you.
Thank you very much, Professor Amr, for your nice presentation. It looks very easy. The operation looks very easy. Thank you very much. So I think I do have a question, dear Professor Amr. If a patient had stress incontinence with prolapse, do you prefer to offer her surgical treatment of stress incontinence the same set or another time?
Another time, for many reasons.
Okay.
The most important is that many of the women, when you correct their prolapse, there will be a change in their complaint. I prefer to do that in another setting. And the incidence of overactive bladder when you do the procedure during the correction of prolapse, the incidence of overactive bladder increases in this group of patients. I totally prefer to do the incontinence procedure in another setting if it remains.
Thank you very much. We have a couple of questions for you, please. So the first question, is the mesh obsolete now or it's just in the UK?
Well, we know that Dr. Wael Aggur had done a lot of effort to make the mesh obsolete, especially in Scotland. But I had a long discussion with Dr. Wael Aggur regarding the options. They'd like to use a natural sort of support, but in fact, they still use in the UK, in some places, the Prolene mesh. And personally, over the past 25 years, I have seen one case of mesh erosion, and all I've done is that, and you usually see that in patients who had already had a hysterectomy, by the way, in a previous surgery. So you're doing the surgery for a vault prolapse. All I need to do is to cut the mesh from the vagina, and the patient was fine after that.
Thank you very much. There is another question. What is the recurrence rate of prolapse for both operations?
Well, the recurrence rate is around 15 to 20%. Of course, there are several factors to affect the results, whether this patient is diabetic or not, whether she's overweight or not, what's the route of the procedure. But we are talking about 80% success rate after 5 years of the procedure. I expect 80% of the patients to get ready to remain happy with the procedure.
Thank you very much. I think the last question, dear Professor, what will you prefer for procedentia, vaginal hysterectomy plus sacrospinous fixation, or total laparoscopic hysterectomy plus sacrocolpopexy?
The most important question here, whether this patient is sexually active or not. If this patient is sexually active, I definitely prefer laparoscopic hysterectomy and colpopexy. If she wants to remove the uterus. If she doesn't want to remove the uterus, then uterupexy. If this patient is not sexually active, I can offer her sacrospinous fixation, but we all know the problems with the sacrospinous fixation, especially with the dyspareunia and change in the vaginal axis. So I'm still quite happy to offer my patients colpopexy, actually.
We have lots of questions for you, Dr. Amr. let's take another one. Does lateral suspension is comparable to sacropexy?
Some people would like to believe so, but I think that the best procedure for apical prolapse is sacral promontory fixation.
The last one, what about fixation anterior pubic bone instead of sacral promontory?
You can do that. Many of my colleagues, one of them is a pioneer in Egypt, Dr. Muhammad Abdel Hamid, started to do this procedure, and he finds a lot of advantages, especially ease of the procedure. But I'm not experienced in this procedure, and I'm quite advocate for sacral promontory fixation. Not because I deny the advantage of anterior fixation, but because I don't have enough experience in the procedure.
Thank you very much for your time and sharing all of your expertise with us today.
I'd like to say hello to Dr. Mohammed Mabrouk. I can see him now. Unfortunately, I have a family occasion, and I'm very unlucky to have to leave now. Thank you again for Professor Yasser Abu Talib, Professor Gasser El-Bishri, Dr. Amr Nabil, and again, a warm welcome to Dr. Mohammed Mabrouk, and we would like to see you again in Egypt in the near future. Thank you, everybody. Thank you very much.
Thank you very much, Professor Amr. That was very nice presentation. Now I'm going to introduce our second speaker for tonight, Professor Gasser El-Bishri. Professor Gasser is a professor of obstetrics and gynecology at Ain Shams University Hospital. He is a former head of laparoscopic surgery department at Ain Shams University. He is a consultant in minimal access surgery at the University Hospital of North Durham, and previously a training fellow in minimal access surgery in Middlesbrough in the UK. Moreover, Professor Gasser has successfully led the Egyptian Representative Committee TLH workshops 13 times since March 2016. So I'd like to welcome Dr. Gasser, and he'll be presenting the total laparoscopic hysterectomy tips and tricks. So would you please start, Professor Gasser?
First of all, I would like to thank you, Dr. Amr, for a very nice presentation. Thank you very much. It's a great pleasure to be here. As you've all heard, we are all very close family. Professor Yasser Abu Talib doing a great job as the head of the Egyptian ERC-RCOG committee. And Dr. Amr, thank you for organizing this lovely webinar. It's a great pleasure to be with Professor Amr Husseini, who was my senior registrar. We worked together, as you've heard, and he taught me actually quite a lot in the field of ops and gynae. And it's a great pleasure to be with Professor Mabrouk, Mohammed Mabrouk as well. I would not forget Mrs. Jihan for her great effort. Just to get things going, I'm gonna talk about tips and tricks in TLH. We've been running the TLH course, which is a joint course with the RCOG. We run it twice a year in Egypt, and it's been actually quite successful, and I would invite, if anybody is interested, to attend. The objective of my talk is actually providing you with strategies. We want to maximize completion of TLH, which means reducing the conversion rate. Reducing conversion rate from laparoscopic to abdominal and reducing complications. And just providing simple surgical steps to simplify the TLH. Why do we do it? We all know it has got a shorter hospital stay, less blood loss, and that's why it's highly supported by Jehovah's Witnesses in England, who refuse blood transfusion, as laparoscopic surgery carries less blood loss. It's got less post-operative pain, adhesions. The patients or the women, they go back to work quicker and with quicker and earlier mobilization. We really do TLH because it gives us actually more surgical satisfaction, and it's much easier than a total abdominal hysterectomy. If you remember the obese women with the deep pelvis, with the small uterus, It's so difficult to do it abdominally. And if you do it through TLH, it's much, much easier. Now, you have to select your patients first. So looking at the previous parity, previous deliveries, if they've had a vaginal deliveries, they've got a wide introital space. And if you've got a big uterus, then you are it's much easier for you to morcellate the uterus and to insert whatever cuff delineation, whatever manipulator you would like to use. Always remember with the ones who've had a cesarean section, especially the ones who've had 3 or 4 or more cesarean sections, there could be quite a bit of bladder adhesions and increased adhesions in general in the pelvis. So it is quite important in counseling those women and discussing with them risk of bladder injury as well, which can happen even with the open surgery. Another point is your BMI. You know, the higher BMI, you're going to limit the pneumoperitoneum because the anesthetist will be shouting. Your degree of putting the head down will be limited, again, because he's worried. Vaginal access is usually difficult. You've got redundant bowels and omentum. You've got excessive fat intra-abdominally. You need some equipment. Very important to have a good camera and very important to use a uterine manipulator, especially when you're starting. Once you've got used to it, as you've heard Professor Amr Husseini saying he doesn't use a uterine manipulator, so it's not a must really after that. You need a good energy source, whether you're going to use a ligashore, a harmonic, a bipolar, but something where you can secure the vessels with. Positioning of the patient, head down. This patient has got shoulder supports. Shoulder supports are actually, they come with all operating tables. They're just usually stuck somewhere in a cupboard where nobody knows that they are there. But they're really helpful because you can put the head extremely down. And as a result, you push all the bowels out of the pelvis. And it actually makes your surgery much easier. And especially if you are, dealing with somebody where you're not going to use a uterine manipulator, then this position is really useful. Using a uterine manipulator, we've got different manipulators. The whole idea is you can move the uterus with, and you've got a cup where you can actually open the vagina. But I will show you that even if you don't have a cup, we can use other techniques. If you've got somebody who's a virgin and you're doing a TLH and you do not want to put any uterine or any vaginal manipulator, you can actually use the myomectomy screw to move the uterus around. So that's another way. Now, or you can use a pair of sponge forceps if you don't have a uterine manipulator. And with those sponge forceps in the vagina, you can easily dissect the bladder of the vagina and open it. The McCartney tube is a very useful thing to have, actually. Some people use it as a manipulator from the beginning, and you can open the vagina on the tip of the tube. But the problem is it doesn't have anything inside the uterus to move it around. So usually I use it at the end of the procedure. If I've taken out the uterus, I've left the tubes and ovaries to be taken at a later stage at the end. Then you can put the tube, remove the tubes and ovaries, and just push them through the tube downwards. You can introduce your needle holder from below, and you can actually use it when you're suturing. It keeps the vagina open and the edges clear. Size of the uterus is really important. If you've got a big uterus, then you've got to move above the umbilicus. Mobility of the uterus sideways, the presence of a cervical fibroid or low fibroid, you've got to be quite careful. And I would advise that you dissect the ureter before taking the uterine. And again, the consistency of the uterus. If you've got a soft uterus, it will be easier to bisect, to morcellate than a firm uterus. Large uterus, you've got to move upwards. So as you can see, there's the umbilicus. This is quite a big uterus. If you try and put your port in the umbilicus, it will make your surgery so difficult. So it's better to move above the umbilicus. You can move up to 4 finger breadths, which is about 10 centimeter. Putting your ports, you can have 2 ports on one side. The lower port, as you can see, are much easier to take the uterine with. Sometimes the upper port will be easier to dissect the tube and the ovary. So you might end up using 2 ports on one side with your assistant putting a port, or if it's a really large uterus, you might end up with 2 ports on either side. Use of Zoladex may reduce bleeding and increase hemoglobin while you are awaiting surgery. It tends to shrink the uterus, so you get a better access. And it's supposed to soften the fibroids, which means that morcellation might be easier. If you've got a big fibroid and it's quite hard, then actually you can have a problem morcellating it. Now the steps, like any abdominal hysterectomy, you're going to secure the round ligaments. Or you can start with the IP, depends, or the uterovarian ligament, depends on your preference, really. I personally start with the round ligaments. I find it easier, and then secure the uterovarian ligaments, and later on take the IP ligaments if I'm going to remove the tube and ovaries. Dissecting the bladder, and that's an important point. In TLH, you do not need to over dissect the bladder of the vagina. Unless you're going to fix it, you're going to put a mesh and fix the vault. That's another issue. As you've heard, you need about 2 or 3 centimeters. But all what you need is just 1 centimeter of bladder dissection to allow you to put your suture. And I'll explain why. Securing both uterine, opening the vagina, and finally suturing the vault. Now, this is a traditional way of putting your trocars, where you get a 10 millimeter port in the umbilicus and 3 5-millimeter ports. And as we said, if it's a big uterus, you're going to move around. You can either place your ports ipsilateral, and if you do that, make sure that the distance between your 2 lateral ports is at least 10 centimeters, so 4-finger breadths. And again, between your port and the camera. And the assistant has different points of placing their ports. Securing your pedicle with different instruments. The one that is commonly used in Egypt is the ligature. You can still use a harmonic, but I would prefer to take the uterines with a bipolar. In some places, like in India, I've seen people suturing all the pedicles. It might be a little bit more time consuming, but actually, if you put extracorporeal knot, this might be an alternative to bipolar or harmonic or ligature and so on. Now, it's better to start with the tubes and ovaries. So you cut it over here, which means they drop away from you, so you can carry on with your procedure rather than having them, hanging down and irritating you when you're taking the uterine. When you're taking the IP ligament, you've got to use a bit of medial traction. This makes the procedure much easier. Here, we're going to remove the tube and ovary from the beginning, and that's again one way of doing it. And then taking the round ligaments. Then once you start dissecting the bladder, you're pushing the bladder. Once you've opened the round ligament, the carbon dioxide escapes in and the space is opened easily. And what you need to do, you need to keep on dissecting until, as you might have noticed, the ring of the cup there. So you need to keep on dissecting until the cup is actually available and you can easily see it, because that's going to be your marking level. So the level of the cup of the uterine manipulator is where you want to take your uterines. You cannot take it above that because you're going to cut along the cup. And again, here, as you can see, we keep on pushing the bladder downwards until we reach the level of the cup, and that's it. You stop at that. You do not need to continue, and you carry on dissecting until you reach the other side. Now here, as you can see from this diagram, the ureter moving under the uterine. If you push the uterus upwards with the manipulator, you are actually pulling the uterine artery away from the ureter. And that's why, in contrast to abdominal hysterectomy, you do not keep on, over dissecting the bladder. With abdominal hysterectomy, you keep on pushing the bladder downward with the gauze because you want to push the ureters away. Now here, you don't need to do all that. As I said, just 1 centimeter off the vaginal vault to allow you to suture, and your ureter will be away from the uterine by just pushing your uterine manipulator upwards. Then you secure the uterine vessels, and it is important when securing the uterine vessels to remember you secure the artery and you secure the veins. It's really important. Otherwise, you end up with a lot of bleeding. I would rather secure the uterine on one side, whatever side you want to start with, and then secure the uterine on the other side, and by using the harmonic or the by using the ligature or the bipolar. And once you're happy that the uterus has become white or grayish, then both uterines have been secured, then you dissect them after that. Now, this is a way of opening the vagina with the sponge forceps. If you don't have a uterine manipulator, sometimes, we don't get it, we don't have it. Then you can use here a pair of scissors. You've got the ring forceps inside the vagina, stretching it, and you keep on dissecting, you keep on buzzing, with the cutting diathermy until you see the ring forceps. A lot of people usually ask at this stage, aren't you worried about burning the vagina? And actually, no, because the ring is touching the vagina quite a long distance, and as a result, it's working like pad. It's like as if you put the insulation pad, so it doesn't really burn the vagina. This is the easier way of opening it with monopolars to the front, and when you get to the sides, because we usually hit the descending cervical, then it's much easier to use again the harmonic or the ligature to either sides. Closure of the vault. You can use McCartney tube to introduce your needle holder from below. If you don't have it, you can just introduce the needle from the top. And whatever suture you use, either a purse string suture, which is you go around, or a few simple sutures, and you can use either a barred suture, Vicryl, Prolene. And just, as you can see, all what you need is just 1 centimeter anteriorly and 1 centimeter posteriorly to be able to close the vault. And whether you put just a couple or 3 simple sutures or 1 suture, it doesn't really matter. It both works both ways. Yeah. Now, a routine cystoscopy. Some people actually do routine cystoscopy after TLH. And when I worked with Mr. Graham Phillips, we used to inject indigo-carmine, which was really great because you've got a red dye that's coming out from the ureteric orifices, and you put your cystoscope. It takes only 1 minute, really, and you're happy, going home happy that you've got an intact bladder, and the ureters are, you can see the dye flowing. The only side effect to that is that, if it's a thermal injury, it might not be apparent actually at that stage. Thank you very much.
Thank you very much, my dear Professor Gasser. That was very informative and very well delivered presentation. Thank you very much. Lots of doctors now trying to do the total laparoscopic hysterectomy instead of the open hysterectomy. So, what do you think the learning curve for the doctor should be?
I mean, it is actually when I first attended a total laparoscopic hysterectomy course in England, and this was a long time ago, and I'm still a registrar. I thought it was a really difficult procedure, and when the instructor was telling us that with time you're going to find that it is much easier than an abdominal, and it is true. It's an easier technique than abdominal, provided you've got a good camera and you've got the proper instrument. When we run the TLH course, usually some of the candidates, they have never done laparoscopy actually. And because we promised them that it's hands-on, then we end up assisting somebody who's never done a laparoscopy to do a total TLH. It is, when they go home and when they go back after the course, I always tell them, start with the round ligaments, start with the IP ligaments, and once you're happy with that, carry on, take the uterine. Once you've taken the uterine, then the next step is to do, to complete the procedure. So it's not a long learning curve. It's a very short one, but start, as we said, with the patient selection. easier cases first, and then you can carry on with the more difficult cases.
Thank you very much, my dear Professor Gasser. We have some questions for you, please. The first one, in the step of vaginal vault closure, as we are using diathermy, can it be left open or still need to be closed with sutures?
I'm sure, from the hemostatic point of view, you can, if you've got a bleeder, you can actually secure it with a bipolar. But opening the vault, you've got to use, and I was very clear about it, you've got to use the cutting diathermy. Because if you use coag, you can actually cause ischemia of the vault. And this is one of the reported problems with TLH, is dehiscence of the vault, because we've overburnt it, so it doesn't heal properly. So I would rather not put so much electricity in the vault. If you are used to leaving the vault with an abdominal hysterectomy, I've never done it in my life. I heard it can be done, but I always feel better just to put a stitch. But sometimes when I'm suturing, the assistant tells me, oh, there's a bit of gas leaking. Now, for that, it doesn't matter. You can have a tiny hole left at the end because it will work as drainage. But to leave the whole vault without suturing, I find it a bit scary for me.
The second question, how to approach the bladder dissection in cases of previous cesarean section?
Yeah, it's really important to be, laparoscopic surgery needs patience. And I would go from the very lateral side and work my way laterally. What I tend to do is I don't put a catheter, a Fullis catheter from the beginning. I empty with an Elaton, and then I use the metal catheter, I insert it inside the bladder and lift it up so I can see where exactly the bladder is. So this way, this technique, and it's actually published, this technique, myself and Graham Phillips, it was how to dissect a bladder in a previous cesarean section. And this technique is very, very easy because when you're using your laparoscope, you can see where the demarcation of the bladder, and you can move your metal catheter to know the extent and just dissect just slightly above it. I hope I made this clear.
Yes, I think it's very clear. Dr. Yasser wants to comment.
Okay, thank you, Gasser, very much. It's wonderful as usual. Just let me to ask you just one question regarding the use of laparoscopy, use of TLH in cases of advanced cases with endometrial cancer. Do you prefer it using laparoscopy, or would you prefer to do it through laparotomy?
Well, actually, when you start opening the spaces, the retroperitoneal spaces, and dissecting the lymph nodes laparoscopically, you'll be amazed that the anatomy is much, much easier and clear. But even if the uterus is small, I would advise to insert the camera above the umbilicus. Don't go through the umbilicus if you're planning to do lymphadenectomy, because it's much easier to approach the retroperitoneal space, and you can see where the sacral promontory is and where the ureter is passing and everything when you are higher up. So if you go higher up, 10 centimeters or so above the umbilicus, you will easily dissect the lymph nodes. You need to have a bag, or if we are working in a place where there isn't enough bags, you can use the gloves to put the lymph nodes, so you're not worried about spreading anything. But I find it much easier because usually women with endometrial cancer are obese. They are usually got diabetes. So the last thing you want is to open their tummy, and they will end up most probably on the intensive care unit at least for a day. But with TLH, you can see them wandering around in the evening.
Thank you very much, Gasser.
Thank you very much. I think, Professor Gasser, you have many questions, very interesting topic. Another question, your opinion in closing uterine arteries by clips alone or in addition to ligature?
I mean, you can put clips like the bulldog clips if you're gonna close them temporarily. Like if you want to do a myomectomy, it's a big myoma and it's gonna bleed, so you want to put a clip to stop bleeding until you finish the myomectomy and then remove the clip. But to put it permanently, well, if you're gonna dissect, and instead of putting a clip, you can just buzz it with the diathermy, because once you've dissected, you've seen the ureter there below, you've pushed it away, and there shouldn't be a problem using diathermy. I never put a clip without diathermy, to be honest.
Thank you. Another question: how can you guarantee avoiding ureteric injury?
Can you guarantee in total abdominis? You can't. Well, if you've got endometriosis, or if you've got somebody with a lot of adhesions, I would advise definitely to dissect the ureter out and away from our field before taking the uterine. You cannot guarantee, but you hope if you don't use obviously you cannot use monopolar diathermy for the uterine, because you will definitely injure the ureter through spread of heat. But if you use bipolar, or if you use LigaSure and you've dissected the ureter, if it's a difficult case, then you shouldn't have a problem. Again, you need to cut the uterine at the level of the cup. So please don't cut it any other level, because then you can run into problems where you get a bleeder, and trying to secure the bleeder, that's when you're going to injure the ureter.
Ureteric injury, yeah. Another long question regarding the use of GnRH agonist, namely Zoladex, preoperative for myomectomy, as it may make delineation between myoma and uterus little discrete. When exactly to perform surgery after giving patient GnRH agonist to avoid making surgery difficult?
I mean, here we're talking about myomectomy, not hysterectomy.
Yes.
We've always read about Zoladex will make the planes more difficult. To be honest, I've never encountered that. And I think that Zoladex will buy us time because usually women with myomas undergoing myomectomy, they usually have a low hemoglobin. So if you give them Zoladex, it will stop the period for a few months and give you time to, fill her up with iron. So I don't think it's a bad idea, actually.
Okay. Thank you very much, Dr. Gasser, for your time and for your presentation. It was a very nice presentation. Thank you.
Thank you once again. It was really a pleasure to be here. Thanks a lot.
Thank you. So it's an honor to introduce our third speaker for tonight, Professor Mohammed Mabrouk. Professor Mohammed is a consultant gynecologist and renowned endometriosis surgeon at UCLH UK. Professor Mabrouk is also a consultant gynecologist with a focus on endometriosis at Cleveland Clinic London. He currently serves as a president of the European Endometriosis League. Additionally, he holds the position of adjunct professor of gynecology at the University of Southern Denmark. Professor Mohammed expertise in endometriosis is widely recognized across the UK and Europe. So his presentation today will be on laparoscopic management of endometriosis. We're really lucky to have Professor Mohammed tonight, and especially after a busy gyne list. I hope you managed to eat your lunch and take a break before the presentation. Thank you very much, Dr. Mohammed.
Thank you very much, Dr. Amr, and many thanks, Dr. Yasser, Dr. Gasser, and Dr. Amr for inviting me. It's an absolute honor, and I really feel privileged. So, and also thank you for this big introduction. I really don't deserve this. I just would like to thank the opportunity to speak about this topic that's very close to my heart. And in 20 minutes, I was really thinking, shall I speak about technical issues, or shall I speak about philosophical issues, or let's speak about the management in general? And I hope you'll appreciate that speaking only about technique is not exactly what we need here, because endometriosis management maybe needs more than this. I will not start by defining endometriosis, because we all know what endometriosis is. Really? Do you really believe that we know what endometriosis is? I don't think so. Because the more we go around the world to teach endometriosis and endometriosis surgery, the more we figure out that the picture of endometriosis that is in the mind of many gynecologists is this: a couple having a so-called chocolate cyst of the ovary, easy diagnosis by ultrasound, and easy surgery by removing the chocolate cyst, the so-called chocolate cyst, and improving the fertility, etc. But actually, this is what happens in the best case scenario, when in 14% of the cases and the rest of the cases, ovarian endometrioma is just the tip of an iceberg. And what we see every day and what is happening in endometriosis, and we couldn't diagnose it before, but now we can preoperatively diagnose the deep infiltrating endometriosis, or endometriosis that goes underneath the peritoneum to infiltrate the bladder, the bowel, the pelvic nerves, the ureter, causing last year, so far, the year is not finished yet, and we have performed 3 nephrectomies for patients with deep endometriosis. And this is what happens in cases where there is also significant impact on the functionality of this patient and on the quality of life of the couple, not only the patient and not only the pregnancy issues, etc. So deep endometriosis, by definition, is when endometriosis infiltrates more than 5 millimeters underneath the peritoneum. Love it or leave it, this is the same definition by the World Endometriosis Society. But let's be larger in our thinking. It's when there is deep involvement of the pelvic organs, when there is involvement of the bowel, the uterosacral ligaments, of the nerves, of the ureter, of the bladder. And obviously, when you see something like this, the so-called superficial peritoneal endometriosis, many times, again, this is the tip of the iceberg. When you see something and it comes to you, yeah, I will ablate this, I will buzz it, I will burn it. But actually, you're just burning the tip of the iceberg, and the iceberg is underneath the peritoneum. It's a neurotrophic disease. It causes neoangiogenesis and also neuroangiogenesis. And this is what creates the real pain of endometriosis. So let's ask ourselves a question. Do we operate all the patients that have endometriosis? The answer is no. We can also offer alternative or different treatments, medical treatment. We can offer fertility treatment, etc. But in patients who do not accept medical treatment or medical fails, we offer surgery. And if I offer surgery to the patient, and if I do a segmental bowel resection, something that I've done today, 2 bowel cases I've just finished. So is there an evidence to support what I'm saying, what I'm doing for excision of deep endometriosis in that way? The answer is in this paper. If you look in 2017 of the British Journal of Obstetrics and Gynecology, the colleagues evaluated national and international guidelines, 152 recommendations. And as you can see here, there is a substantial variation in the recommendations, and the quality of evidence is poor. So if I have to give you some concepts about the surgery for endometriosis, let me start by these concepts. We don't aim with endometriosis surgery to do a surgery. We aim with endometriosis surgery to do one successful surgery. As complete as possible on the disease, as conservative as possible on the functions of this lady and on her nerves and on her reproductive organs. I operated patients who have been operated several times, and every time you look to the patient who has been operated for endometriosis 7, and I have operated a patient that has been operated 16 times before. So we aim at operating this patient one successful surgery. Then if she has a recurrence afterwards, it's a recurrence. But if we go inside, cut some adhesions, buzz some stuff, and then we need to reoperate on her again after 1 year, this is not a recurrence, this is a persistence of the disease. We need to do every possible effort to offer this lady. Either we don't operate on her, or when we operate on her, we offer her one successful surgery. And this is not a one-man show. This is a multidisciplinary work, and there should be integration between the endometriosis specialist. And this is a word that maybe we don't hear it a lot now, but it is coming more and more. And in many countries now, they're focusing on defining who an endometriosis specialist is and criteria for being an endometriosis specialist. So it is not something that anyone can do. Multidisciplinary surgery, because as you have seen, it involves the bowel, it involves the bladder, it involves the nerves, the ureters, etc., etc. And again, unless you're a pelvic surgeon and you're authorized and you're trained to do so, you need to do this surgery with a multidisciplinary team where you can offer to this patient a successful surgery. And obviously, this patient has a benign disease that's affecting her and her reproductive age and impacting her quality of life. This is not cancer, this is not a life-threatening condition. However, it impacts the patient like even worse than cancer. So patients should be given options and information, and we help these patients to make their informed decision. And we inform them that during the surgery, we can change this decision from one thing to another. Example, I'm doing a disc resection for a patient, and that's what I was doing an hour ago. And we said, fine, we will do the disc, but if it doesn't work, we might need to do a segment. And the patient is well informed before surgery that we will try to do a disc, but if it doesn't work, we will do a segment resection. Or we can do a ureterolysis, but we can do a ureteric reimplantation, stuff like this. So the decision can be changed. And the counseling to the patient should be personalized. In this context, there is no one size fits all. It's not that I counsel all the patients, Madam, you have bowel endometriosis, you will have a stoma for the rest of your life, you'll have a colostomy. No, it doesn't work like this. There are patients that are at high risk of having a stoma, yes, patients that are at low risk, and this is what the patient should know. And in the counseling, and now it's facultative, it's yes, on demand, but it will be obligatory in a short time that you have to tell your patient the rate of complications in general that are associated with this sort of surgery and your personal complication rate. And the transparency in this context is absolutely important because it's not permitted, and it will not be that we do the surgery, we have problems either perioperatively or delayed postoperative complication rates, and we counsel the patient on the basis of what the literature says, and I will show this to you. And at the end, with this disease, we need to be conservatively radical, and we have to be familiar with this word. They're contradicting words, yes. How conservative and how at the same time radical? Conservatively radical because, as I said to you, you have to be as complete, as adequate as possible on the disease. This is the patient's chance to be good, to be happy, to have a better quality of life, less pain, etc. But at the same time, you aim at conserving her organs, at being conservative, at giving her a chance to have a pregnancy, to have a functional organs like the bladder, like the bowel, like the sexual functions. And here, this is one of the best, in my opinion, best papers that have been written in endometriosis. It's about reducing low-value care in endometriosis surgery. We know that certain things have definite harm, and other things may have a potential benefit. Example, the patient that is 25 years old that has a 2-centimeter cyst on her ovary. You see her in the clinic, you say, oh, madam, you have a chocolate cyst on the ovary. We need to remove it. Is this good or bad? It's bad. Why? Because maybe she's asymptomatic. Maybe if you remove this, you will reduce her ovarian reserve, and we know this. She's trying to be pregnant. Then, if you offer her an intervention that has definite harm or a potential benefit, this is called low-value care. And if you offer this patient a low-value care, you're not. Maybe we need to think endometriosis. Endometriosis is a benign disease, yes, but it is a global disease that's affecting women in their reproductive life. Before being engaged with the disease, we need to understand the disease. We need to understand the patient's objective. There is no one size fits all. We need to make a very precise diagnosis before the surgery. And thinking endometriosis, you will ask me, okay, Mohammed, what's the best treatment for the patient? The best treatment is this treatment that is tailored to the patient. Tailored. The patient is in the center, and we are offering her a holistic approach, but tailored to her. Because, I will give you an example, A patient that has a 4-centimeter endometrioma, if she's 20, the management is different. If she's 30, the management is totally different if she's 45. And the counseling that you will give to the patient is totally different according if she wants a pregnancy, if she completed her family, etc., etc. And I would like to remind you that endometriosis surgery, laparoscopic, robotic, whatever it is challenging. And the challenges are not only in technical challenges, it's the diagnostic challenge, technical challenge, and the decision making. And I will give you some quick examples for this. They say that endometriosis is an oncomimetic disease, which means it's a benign, yes, but it has a biological behavior that looks like cancer. It looks like cancer, but it's benign. It's oncomimetic. It simulates. It's similar to cancer. Fine. But let's see. In the diagnosis, remember 2-3 things. The eyes do not see what the mind does not know. You need to learn to do ultrasound scan for endometriosis and to focus on deep endometriosis, not only the chocolate cyst. The surgery is based on the patient counseling and the patient choice. So you have to see the MRI images, to have to interpret the MRI images, and to discuss with the patient all the options that she has. We are not treating lesions. We are trying to help this patient to achieve her objectives. And you need to minimize the surprises during the surgery. And this is why precise diagnosis is very important. You cannot go in endometriosis surgery with the concept of, Madame, we will do a laparoscopy and open and see, or laparoscopy and treat, or all these things that we used to hear about 25 years ago. But now they are obsolete. We shouldn't do this anymore. Decision-making in endometriosis is not easy because preoperative decision can be changed during surgery. But let's come back to the oncomimetic disease. Let's take an example of endometrial cancer. It's an algorithm. Patient that has a stage 1, grade 1, has this treatment. And it's very easy to make a decision here because it deals with patient survival rather than her quality of life. And I'm sure that if you say to a patient you have cancer, she will not discuss a lot about what your decision or what you're suggesting her, because this is cancer. In endometriosis, patient decision or decision-making is totally different. We are here, the objective is pain, fertility, or quality of life, which make the decision even more difficult and the options much, much more. We don't have a one-size-fits-all. We don't have, and again, this is a neurotropic disease where we have a lot of technical challenges. The technical challenges, if you look to this picture, for example, this is a picture of a frozen pelvis, and this is exactly what we face in most of our cases with endometriosis. If this is an oncology, you put a laparoscope inside, you take the laparoscope outside, and you say, Madame, you need radiochemio, or this is, we will give you neoadjuvant chemotherapy if this is an ovary. And I would show you here 2 examples. This is a radical hysterectomy. And when I used to do oncology some years ago, for me, a radical hysterectomy, a laparoscopic radical hysterectomy, when they used to do laparoscopic radical hysterectomies, was much easier because look here, this is a parametrium, left parametrium, and this is the left parametrium. We're doing the same parametrectomy for a patient that has cancer. This is a patient that has endometriosis. And look how glued the parametrium and retroperitoneum is with endometriosis. So we need to do excisional surgery, and in excisional surgery, and this is the division, either you do an excisional surgery or you do some surgery. And again, in the excisional surgery, again and again and again, we need to be fertility sparing and we need to be conservatively radical. This is based on your proper knowledge of retroperitoneal anatomy. This is extremely important, and I cannot stress enough how important it is to understand retroperitoneal anatomy, but not only the structures. It's also important to understand neuroanatomy and neurophysiology. What do these nerves do? It's not only a nerve sparing, it's nerve sparing for which nerves, and if we sacrifice a nerve, what problems should the patient have or could the patient have? And we need to know, obviously, our instruments, etc., etc., and we need to train to be pelvic surgeons, but at the same time performing multidisciplinary surgery. This will take us to some open questions, because these questions, unfortunately, so far do not have a lot of answers, but there is an agreement now across the globe that these surgeries, these patients deserve care. And 191 million women around the world that have endometriosis need particular attention, and they need to be treated in endometriosis centers. And the open questions are: endometriosis surgery, is it the singer or the song? Is it the disease itself? And this is a question that has been answered by my friends Ludovico Muzzi and Miller, where they said, yes, it's both. The song is difficult, but the singer should be well trained, and this is a surgery that should be done in particular centers. And this is the question that we are trying to answer now through the European Endometriosis League and through a big Delphi study that is involving multiple endometriosis experts, several experts from all over the world. We are trying to define who should perform the endometriosis surgery, and an acceptable system that audits the endometriosis surgeons and the endometriosis centers and the criteria to define endometriosis centers and surgeons around the world. And why? Because if you are a gynecologist, you are like the driver that has a license B to drive. Endometriosis surgery is a little bit like driving a truck. Without the proper knowledge of anatomy and proper knowledge of the disease and neuroanatomy, etc., maybe you are not doing the same job. Exactly, if you're driving a license with a license B, driving your fantastic car, whatever the type is totally different from driving a truck. And how to train and audit the endometriosis surgeon is the question that we are trying to answer now. And by this, I would like to conclude, and thank you very much for your attention. Happy to answer all the questions.
Thank you very much, Professor Muhammad, for this very informative, clear presentation for a challenge we face every day in our clinic. Thank you very much. We have a couple of questions for you, please. The first one, cystectomy versus aspiration in a patient with bilateral endometriosis, and she's seeking fertility.
So the question is a patient that has, let's try to imagine, the scenario.
So
if the patient is trying to get pregnant, she has bilateral endometrioma. The word bilateral endometrioma is at a high risk of reduction of AMH with her surgery. She wants to get pregnant and she's happy to get IVF, to have IVF. Then I would offer her, first of all, AMH to know what her ovarian reserve is. Number two, I will ask for a fertility consultation. Fertility consultation will give us a clue if she is about to have IVF and this is the proper time for her to IVF. That's good. If not, she can have ovarian stimulation, and she can have egg freezing or embryo freezing according to her plans. And then, if there is any indication from the fertility team, then we do the aspiration, drainage, laparoscopic drainage, and we prepare the patient for them to do the IVF work. Aspiration of endometrioma transvaginally or by ultrasound is not an acceptable method for aspiring or draining the endometriomas. Making a small hole in the endometrioma and suctioning the endometrioma just because we don't want to reduce her ovarian reserve is nothing, because she will have the recurrence of an endometrioma after tomorrow. We are just making her pay money, do a surgery that may be useless, but this is not in any sort of or form or shape in any guidelines, and it's not supported. To go inside, make a small hole, take the chocolate material out and say, Madam, I just aspirated your endometriomas because I don't want to reduce your ovarian reserve. So the options here are either we treat or we don't treat, surgically speaking. If we treat, there is strong evidence to support removal. And there are alternatives? Yes. There are alternatives that are opening drainage, GnRH analogs, and IVF, or ablation by any sort of form or shape, plasma jet, whatever it is, or alcohol sclerotherapy. But in this context, and unfortunately, this is something that happens and it continues to happen, we see colleagues doing laparoscopies, going inside, small hole inside, suctioning of the chocolate material that's inside, washing a little bit. We didn't want to remove because we didn't want to reduce your ovarian reserve. So after 2 months, you do the ultrasound scan, same exact situation. What have you done to the patient? I'm not sure. So I hope I answered the question in a proper way.
Yes, thank you very much. Another question, what about transperineal ultrasound, 3D, 4D, for diagnosis of morphometry of muscle affected by deep infiltrating endometriosis?
That's a very, very good question. I'm sure that this comes from an experienced sonographer. We were one of the first groups in the world to publish on this in 2015, 16, something like that, where we did 3D, 4D transperineal ultrasound. It's very, very helpful. And it helps for the patients who have pelvic floor hypertone. So again, who believes that endometriosis is only a surgical solution is wrong. No doubt about this. And who thinks about either or, it's not the same philosophy, it's not correct. It's the combination of everything. So it's not either medical treatment or surgery, it's both. It's not either surgery or IVF, it's both. And add to this physiotherapy. We used to believe that physiotherapy doesn't do anything for endometriosis, but actually it does. It does. Why? Because there is a pelvic floor muscle hypertone, and this is what you can diagnose with 3D, 4D ultrasound of the perineum. You can diagnose a sphincteric hypertone, either external A sphincter or the vulva, the vagina. And these patients have superficial dyspareunia and have also rectal dysfunctions related to this hypertone. So you diagnose this, you direct the patient to have her pelvic floor physiotherapy. Together with your surgery, you sort the problem out. But if you believe that with your surgery alone, you are the surgeon, you will resolve everything, I'm not sure if this is correct. So I hope I answered the question about the three. It's very good, it's very important. You need to learn it. And it's a part of the armamentarium of the diagnosis in endometriosis. Very, very important.
Yes. Another question, please. When would you recommend egg freezing in endometrioma patients? And do you have a cutoff age or AMH levels?
Again, this is all tailored and it depends on the patient that you're dealing with. If the patient has high risk of reduction of her ovarian reserve with the surgery, I recommend it. So patients who haven't completed their families, who want children, I suggest it for everyone who has an ovarian endometrium, ovarian infection. Then there are patients who accept, there are patients now who freeze their eggs for social reasons. But you suggest, your role is to give options and information. But there are patients that you strongly suggest, you say, please do it. It's very important. Where a patient, for example, who has had multiple surgeries on her ovaries, patient who has big endometriomas, bilateral endometriomas, patients who have low ovarian reserve. And low ovarian reserve, you can suggest either freezing or if her conditions are good, you say to her, Madame, have your IVF, have your baby, and then come to me. Because obviously, who does fertility knows that egg freezing is one of these questions that need to be resolved. But it's an option now for endometriosis patients, and this is an option that needs to be explored. I recommend everyone who does endometriosis surgery to do AMH for his patients who are in the reproductive age, who want to have pregnancies before the surgery. However, why? Because unfortunately, sometimes this is reversible after the surgery, but many times it's irreversible damage to the ovary. The patient comes to you, you remove her ovarian cyst, and after the surgery, she has irreversible reduction of her ovarian reserve. If you have it before the surgery, also for medical legal purposes, this helps you to defend the situation, but also for her fertility, if she has a very low ovarian reserve, why would you operate on her? You direct her to her fertility, egg freezing, whatever. And there are patients now who do 1, 2, 3 cycles of egg freezing before any surgery. And it's available and patients like it. I hope I answered.
Thank you very much. It was a clear answer. I think Professor Yasser wants to speak. Please, Professor Yasser. Professor Yasser, you want to speak?
Okay. Mohammed, thank you very much for, yes. Do you hear me, Mohammed?
Yes,
Amr,
yes.
do you hear me?
Yes, we
Okay,
can
that's
hear
fine. So thank you, Mohammed, for your wonderful presentation. And thank you very much to be here with us after a long day of working over hard cases, I know. We are appreciating that very much. Just to question Mohammed, the first, do we have certain limitation in using laparoscopy regarding to the size of endometrioma? So say that we have a very big endometrioma of 10, 11, 12 centimeter. Would you prefer to do it laparoscopy or by laparotomy? Number one. Number two, and if it's set, whatever the situation is, if you are going to remove the endometrioma, do we have any rule for ovarian reconstruction and just clothing the ovarian dead space to improve the fertility or improve the outcome or prevent the adhesions?
So I am not aware about a limit for laparoscopy. And in my opinion, I don't recall indications for laparotomies that we do for endometriosis patients. Sometimes if there is a doubt of malignancy, but we're not the surgeons, we refer them to the oncology colleagues. And sometimes maybe if there is a massive uterus of, I don't know, but anyway, there is no limit, and endometriosis is laparoscopy until otherwise proved. And I recall here one of my teachers, Arnaud Vatier, who said, if I operate a patient and I find by chance endometriosis, open her, I will close her and put a laparoscope and operate on her. Just to be a bit of an extremist to explain the situation. So this is the first question. The second question is closing or not closing. So now, if we think about the ovarian reserve and the impact of leaving the ovaries open after endometrial surgery, I always ask my colleagues who are advocates for leaving the ovary open, if you're doing a laparotomy, would you close the ovary, yes or not? 99% of them say yes. I say fine. Changing the approach does not change the surgery. If you open, if you are doing a laparoscopy, we close. Why do we close? We close for two reasons. You need to achieve hemostasis. And for achieving hemostasis, you either burn the ovary, barbecue the ovary, or you suture the ovary. We suture the ovary. And there is a randomized controlled trial, 27, that demonstrated that compared this to this. Massimo Pellicano in Italy. It's published on fertility and sterility. And it is closure versus non-closure, ovarian reserve, AMH, and antiphoric count after surgery. And it is clear that if you do selective coagulation versus closing of the ovary, it's less. Obviously, the advocates of non-closure, they say, yes, you can create inflammation inside the ovary, etc., etc. One, there is no evidence on that. Two, the common sense says if you use a rapidly absorbed suture, you close, you just compact the ovary, close the dead space. You don't have an exposed surface, you don't have adhesions, you have less adhesion, and this is just a common sense. So I personally remove an endometrioma, close the ovary in all the cases.
Thank you very much. It's wonderful. Thank you, Mohammed.
Thank you.
Thank you very much, Professor Mohammed. I think we're out of time, and we need to wrap up here. So thank you very much for your time and for your presence with us today.
Absolutely a pleasure, and thanks for the kind invitation. It's always a pleasure.
Thank you. At the end, I want to take a moment to thank all our esteemed professors for tonight, Professor Gasser, Professor Amr, and Professor Mohammed for their invaluable time and for their presentations. And I would like to hand it over to Professor Yasser. Thank you very much. I would like to hand it over to Professor Yasser for the closing remarks.
I just would like to thank you also, Amr, because of the massive effort that you did for organizing this and sending message and arranging and organizing everything. You have been a star. So thank you very much.
No,
sorry, Dr. Gasser.
No way. Okay, that's fine. I think it's a great night. It's a very great night to thank everyone participated in this webinar. Thank you, Amr, very much for your kind and hard work that you have done over the last 2 months. And as well, thank you very much for great professors and colleagues, Professor Muhammad, Professor Gasser, and Professor Amr as well, appreciating your attendance and your participation in our activity. And I think everyone in the participants is very interested in know more and more regarding to endoscopy again. So I think it will be more wise to arrange another webinar discussing more issue related to endoscopy again, and this will be most probably coming year. Most probably it will be during Ramadan or after Ramadan by 1 month. So if all of you are happy with that, we are going to contact you again. Professor Gasser, Professor Amr, Professor Muhammad, if you don't mind, we are going to contact you again in Ramadan just to say Happy Ramadan, first of all, and ask you if it's possible to share your knowledge with all of us and with colleague as well for a new era of laparoscopic surgery where we are going to discuss another new issue. So thank you very much. At the end, I would like to just thank you all attending our webinar, and I would like just to read the attention to our coming meeting, International Congress, dated 11th and 12th of December in Egypt. If you want to participate in this great event, so it will be a great thing to contact our secretary and to go through our website to register your name. As you see here, the heads of the meeting will be Professor Dr. Muhammad Aburghar, Professor Dr. Gamal Abu Surur, Professor Dr. Hassan Salam. I am the president of the Congress, and dear colleague Wafa will be the Secretary General. Next slide, please. As I announced that all the group coming from England, the chairs and the heads of the Royal College back in England will be there. Miss Rani, who is the president of the Royal College, Hassan Shahata, the Professor Hassan Shahata, who is the the chair or the second chair of the Royal College of Obstetrics and Gynae, and the assistant, the professor of Obstetrics and Gynae in England, as well Professor Sharif, who is responsible for the MENA region, Asma, who is specialist for fetal medicine, and the CEO of the college will be there, Kate Lancaster. Next slide, please. And it's our pleasure as well to announce that the chairs of the MENA region will attend the meeting as well and have a wonderful presentation during our meeting, coming from Jordan, from Qatar, from Kuwait, Dubai, and Saudi Arabia as well. I'd like to announce as well that, next slide please, that we have lots of webinars. The most important of them are Urogyne. However, I will tell you just one thing, which is might be actually, it might be difficult actually to accept more colleagues or attendee to the Urogynecology course because we are full of the number. Total laparoscopic hysterectomy course is still their places, infertility course is still their places, and as well the fetal medicine and intervention of the fetal medicine will be there, and all of them are available for your attendance. As well, it gives me a great pleasure to have a community-based activity, which is against legalization of female genital mutilation in Egypt, and we are going to hold a special meeting and special course to antagonizing this legalization issue through the Ministry of Health and as well the Royal College of Obstetrics and Gynae. It will be just one day before the Congress, 10th of November, where we are going to train postgraduate doctor and recently newly graduate doctor to counsel for stoppage of legalization of medicalization of the FGM. And lastly, thank you very much for attending our conference and looking forward to see you in the coming webinar. It will be January, as I said, and its title will be a great problem that we used to be faced with all the time. It's following increase the cesarean section rate. It's placenta accreta. Lastly, thank you very much, and hope to see you soon. Thank you. Thank you, Amr.
Thank you very much.
Yes. Okay. So
Thank you very much.
okay, thank you very much. Thank you all, and we can leave now. Thank you. Have a very nice night and nice day for everyone. Yes. Bye.